My name is Pauline Navarro. I am a physical therapist getting your TB in your class, Dr. Bustillo, Extremity Mobilization. And this is the upper extremity video for the Extremity Mobilization class. Today is July 2nd, 2011. This is my husband, Bob, who has kindly assented to be my patient for the day. I'm going to assume that he's only 38 years old, as the case study said, and has been in that cast for 7 weeks after an open reduction internal fixation. And as your commentary said for the case study, he's stiff in his shoulder, 90 degrees flexion, abduction. He is and in limited internal rotation and external rotation, 60 and 30. And he's quite limited and very painful in his elbow, only about 15 degrees play around the 90-degree angle. And he's remarkably stiff in his wrist, also about 15 degrees play into extension or flexion after having just had the cast removed 2 days ago. I'm going to assume there's no cervical or thoracic sequelae from this, because you didn't comment on it in your case study. Besides that, that's not what this class is. So we're going to assume he managed to avoid all those problems. And I'm also going to assume that there's no precautions from the physician limiting the amount of weight bearing or pressure that can be done, that he's completely healed. It's all a matter of regaining joint and soft tissue play, mobility. So, let me get my notes, just like I would in the clinic. What else am I assuming? Okay, yeah, that's right. So, in my thinking, he's been in this cast and probably holding it in a sling-like position for quite some time with this scapular-thoracic joint out of whack, elevated and protracted. So I'm going to assume he's actually got some limitations in retraction and depression, which is going to affect the glenohumeral joint mobility from the rhythm being off. I'm also going to assume, I keep assuming a lot, but we have to, that this is going to be a grade 3 mobilization, and it's justified to do that in an oscillation movement, slow and gentle, to one, help him relearn the motor memory of what the scapulothoracic rhythm is supposed to be, and two, gently help him stretch it back into retraction and depression. Of course, I followed up with the home exercise program to help him learn his own way of stretching and mobilizing. So, these are going to be grade 3 mobilizations into depression and retraction. Could you please roll over on your side? Sorry about the dining room table, it's the best we've got. Okay. Alright. Okay. We liked this last week, huh? Okay, I'm going to go first, grade 3 mobilization into depression. You alright? Mm-hmm. Okay. And here we go. Well, I'll show the full range first so you can see. So here is the full range here and all the way up. Grade 3s are range up to the end of the motion. So, I can't do the 2 to 3 second per 2 to 3 per second recommended for actual stretching, because it's too great of a range for me to manage that fast. But we can at least get through. Actually, I can feel you relaxing. It's amazing. Okay, that's been 10, and now I'm going to do the grade 3 mobilization of the scapulothoracic joint into retraction. I don't actually have to change my hands too much. I'm just going to put more pressure on my thumb, being our eminence. So, now I would normally be able to bend over him more because I don't have the right table. I can't quite get in the position I would want. And our bed was way too low. It would hurt me. 9 and 10. Okay. Let me check my notes. Yes, those are grade 3s. Alright, could you please roll over on your back? I'm going to come over and move the camera. Just relax for a second and I'll get you. come over, turn off the camera, and reposition. I hope you can see me. Anyway, now I'm on part 2 of the shoulder complex, and I am heading over to the glenohumeral joint. I'm going to assume that, again, with the assumptions, the acromioclavicular joint has been somewhat mobilized in a position it probably needed to be anyway when I was doing the scapulothoracic retraction. Probably even the depression would affect the acromioclavicular joint. Given the nature of the assignment, I'm going to stay just with the glenohumeral joint. I'm going to assume that there is a capsular pattern happening in the shoulder after having been adducted, internally rotated, and held rather stiffly against the body for so long. And so I'm going to try to increase the flexion and abduction through mobilizing the capsular pattern. I'm going to aim for a grade 4 again, not again. I'm going to aim for a grade 4 on this one to focus on the actual stretching end range feeling that Maitland talks about, being able to do an oscillation 2 or 3 times per second at the very end of the limit of the motion, very small oscillations. In order to get a better end feel, I have to say, I've never really experienced an end feel in that way. I've always done it in the slow stretch way, but always willing to try something different. So, here we go. My first one is going to be a lateral flexion in capsular pattern stretch. I think actually he calls it, here we go, lateral movement in flexion. That's what he calls it, not lateral flexion. Oh, sorry, don't forget, you've got a very sore elbow and it's stiff here and painful, and this is pretty stiff too. So I'm going to go ahead and bring you up carefully. I can't do this motion exactly as Maitland recommends in his book or on the CDs because, of course, okay, you're no longer stiff. He can't do that. So, you're stiff and painful here. I got you, you don't have to worry. So instead, I am going to support you here, and I'm going to hold you carefully here so you don't get hurt. There, now I've got your shoulder. Do you feel safe? Mm-hmm. Hey, I guess he has to say that, huh? It's an automatic question. And I'm going to push your shoulder out into the end of your motion so that Dr. Bustillo can see it's actually quite stiff. I don't actually get too much play, but I'm going to go to the end of it here, and I'm going to try for 2 or 3 mobilizations, oscillations, I mean, per second. 1, 2, 3, 1, 2, 3. I'm not sure what you meant by 10 oscillations, but I'm going to consider each second a cycle of an oscillation. Darn table's moving with them. I think if I had a mat, it wouldn't. Okay, we're going to call that 10. Okay, we're going to bring your arm back down. I need to move the camera angle so you can see the next mobilization. Alright, why don't you scoot over so that you can be comfortable. Let me turn this up. You can't remember if I also mentioned one of the reasons for choosing these 2 mobilizations of the glenohumeral joint for stretching out the capsular pattern is that if we improve in these areas for flexion and abduction, as Maitland says, these will help. You automatically get the side benefit of improving internal and external rotation. So to me, these are nice overall mobilizations of the glenohumeral joint for everything, for flexion, abduction, internal and external rotation. I mean, I don't think that's all I would do, of course, but for the purpose of this project, that's the 2 I'm picking. So now I'm going to do longitudinal cotted direction mobilization, grade 4 still, for stretching. And here we go. I hope you can see it okay. Alright, let me get my bearings here. That's right. Okay. Oh shoot, you're not going to be able to see his joint. I didn't think about that. Okay, well there's his joint. And then I'll go like that so you can see where his joint is. You can see that right there is the acromion. It's not moving, and under here is. So I'm going to put my hands here. You know, can you move a little closer to me, please? Squeaky table. A little bit more. Sorry. There you go. Okay, now we're in a good position. I like that. So, okay. I'm just below, right where the humerus begins, and I'm going to push to the end of the movement here. I'm going to do that again to test what the end is. Right there. I'm going to stay pretty much at the end. And 1, 2, 3, 1, 2, 3. I'm just doing that for the benefits because I don't know if you can actually see it. And I'm going to call that 10 mobilizations. I wasn't. Don't tell me now. Okay. Alright, you can scoot back over. Actually, probably feel fine, huh? Mm-hmm. Alright. So we're done with the shoulder complex, and now we're going to move into the elbow, which is very painful. We're going to assume a little bit of edematous, pretty much stuck, excuse me, more or less in a 90 degree with a little bit of movement back and forth, 7 or 8 degrees in each direction, probably stuck in some degree of neutral pronation and supination. Not for the purpose of this video, but under a real clinical situation, I would probably check for some kind of nerve entrapment syndrome of the radial nerve, perhaps see if there's any referred pain from thoracic outlet. Over time, do the neuroprovocation tests that Maitland refers to, which I really like. And, you know, in general, do much more than, of course, this video can show. But for this one here, I'm going to focus on easing the pain of the 3 joints the best I can with grade 1 and 2 oscillations, and then moving into grade 3 minus or 3 oscillations to try to gently begin to increase some amount of mobility. Let's see, I'm going to assume, of course, there's no pins or anything else impeding the joints themselves. We will have reviewed the radiographs to make sure that there's nothing in the way of the joint, that the pins and screws have been further away from the actual joint, so I don't have to worry about that. I just want to return the accessory motion to all the joints with as little pain as possible, and also hopefully decrease any edema that may be there through the grade 1 and 2 oscillations. So the first one I'm going to do is a superior radial ulnar joint. I'm going to do an anterior posterior mobilization, grade 1, gradually moving into grade 3 in supination, and then I'll do it in pronation because it seems to flow well together. So, of course, I can't really do it in full supination because he wouldn't have that much motion. So just the best I can. I'm going to keep you comfortable like that, I hope. I've been surprised at how much I can really actually feel the radius and the play he's gotten here. Okay, so here is the head of the radius. Right there. It's got a lot more forearm muscle than my son would have had, but he didn't want to do this with me. Alright, superior radial ulnar joint. I've got my thumbs over the very proximal part of the radius, and I'm going to start with very gentle. Oh, my hands are in the back supporting the ulna, and here we go. You can probably barely even feel that, huh?
Yeah, barely.
So I'm doing 2 to 3 per second if I can, just to try to ease up the pain. We're going to assume that about now you say, oh wow, I feel better. And I'm going to go into grade 2.
You're wonderful.
Oh yeah. He's paid to say that. And now I'm going to go into grade 3. I think that's what you meant by easing from one grade into another. I probably wouldn't be able to go that far on the first treatment with him, but maybe. And that's 10. So that was in as much supination as he could handle. Let me check my notes real quick. AP supination, yes, and AP pronation. I would pronate him a little bit more. I'm not sure if you really need to see that one. Okay. And again, going back. Are you getting sore? He did a lot of yard work, so his muscles are a little sore. Okay, there's grade 1, grade 2, grade 3, maybe 4. Let me see. Nope, there's 4. Okay, 3. I'm really pleased to be able to feel that in the back here, how much movement there is. So that was the transition. And now for the radial ulnar joint, I'm going to do posterior, anterior, and the radial ulnar joint. Maitland really likes all these for increasing flexion and extension, and I think a nice side benefit is it's going to increase the supination and pronation also. So here we are. You have to hold it Oops, sorry, I forgot you have a broken elbow, I have a hurt elbow. So he's stuck here. So I can't do it in as much extension as Maitland would like me to do, but I'm on the wrong one. No, that's right. Okay, here we go. I'm gonna find your radius. There we go. Sorry, I'm squeezing your muscles a little bit too much, huh?
That's okay.
I'm also on grade 1 there. And moving into grade 2. And grade 3. And that's good. Okay, relax your elbow. So for the last elbow mobilization for this demonstration, I will do the longitudinal cotted radial ulnar mobilization grade 1, hopefully moving into grade 3. I like this one. It's also got the added benefit of increasing, well, I like all of them, but this one here appealed to me because it also can help increase the wrist abduction or what you can call ulnar or radial deviation. So that tickled me because I'm sure there's some limits on the wrist in those movements as well as just flexion and extension. So I would probably not do this kind of mobilization unless I had some amount of mentoring from someone who had been there, done that already. But given this class and how much I've learned, it's a real fun thing to do on bottom. So, alright, I'm going to try to grasp the distal portion of the radius with my thumb and finger. Try to keep the wrist more or less neutral and pain-free, especially given this guy's wrist, which is stiff. And, oh, you know what, can you move a little bit closer to me? There you go. There you go. I like that better. There you go. There you go. Rested against my trunk. I've got this arm here, well, supported, I hope. Yep, there we go. And I'm going to just pull up, hopefully in just the grade 1, a little tiny bit. And now I'm going to oscillate it, assuming that that hurts, but it's going to slowly ease it up. And there's 10. I'm going to go into a little more. Can you feel that separating inside?
A little bit.
Are you just saying that? Or serious? I know, it's kind of cool. And now I'm going to go into grade 3, just to see what grade 4 looks like. Okay, there's 4. So yep, I'm in the grade 3 range. Oh, with the assumption that that's not hurting. And we're going to call that 10. Definitely would have to have a better plinth that I can raise and lower. That was too high for me. Alright, and so that's it for the elbow, and now we'll move on to the wrist. So I have taken my patient off the table and put him in a chair with a supported position here. Because of his painful and stiff elbow, I don't think I can do wrist mobilization on the plinth or table unless I had one that I could really lower, but then he wouldn't be supported. So anyway, now I've changed it from the Maitland supine to sitting position to adapt to his elbow, of course. He's got a stiff wrist, not a painful or edematous wrist. And since most flexion and extension comes from the radiocarpal and midcarpal area, according to Maitland, and that one should have about 85 degrees of flexion and extension in either direction, and our poor patient only has 15 or so, I've decided to stick with mobilizing those two areas, the radiocarpal and midcarpal area. I'm going to stick with grade 4 mobilizations as a stretching option, and of course supplement with home program and the like, but for mobilization purposes I'm going to stick with grade 4 in this video. So my first one is going to be a midcarpal localized flexion where of course obviously he probably couldn't do much more than this, but for the purpose of the video we're going to turn him around so you can see what I'm doing. So I'll probably be standing for my body mechanics, and I'll have my fingers along the proximal row of the carpals in the back, the posterior part, and my thumbs in the distal row of the carpals here in the center in the midcarpal area. The whole point being to counter pressure back here, what my thumbs are doing in the front as I flex. I'm stabilizing the hand also. Okay, so that's his movement. We're going to pretend that's all he's got. So I'm going to do grade 4s. We're pretending that's the end of his movement right there. And that was 10. So now we're going to do mid-carpal extension, grade 4. Again, he'd probably be like this, but for the purpose of the video to show it, I'm going to put him in this position here. I've got my index fingers against the distal row of the carpals anteriorly, and I've got the thumb pads of my thumbs, of course, along the joint line between the proximal row and the distal row here. There you go. And the primary movement is not from my thumbs, but from my 4 fingers underneath, pulling up into extension. And I'm going to pretend that we just went from neutral to his limit, and here is grade 4. Since he doesn't have any actual real problems, I'm a little bit nervous to cause them by doing this, but it's interesting to feel the movement you've got. And that was 10. Okay, that's done with that one. Okay, and the final mobilization is going to be radiocarpal extension, one of the primary joints for extension and flexion according to Maitland. The 4 fingers are the front right along the proximal row to stabilize along the triquetrum and the lunate, and my thumbs are holding it on the other side, pretty much the same place, trying to get to the mid-carpal and the, there you go. Okay, and my movement is not one of going like this, as I would have thought, but one of dropping and holding the proximal row as it extends up and over the radius. I have to say that this guy here is pretty stiff. When I compare him to my kids, they have a lot of movement. Oof, I felt a click. I didn't like that. I'm going to distract a tiny bit. There you go. Okay, so I'm going to do grade 4. We're going to assume that if I compare him to his left side, it's got a lot more mobility on the left side. So here we go, grade 4. I've been doing it actually while we speak. There. That's better. Grade 4. Okay, thank you.